dealing with the approach to bone marrow aspiration and biopsy examination. So before reaching to approach to bone marrow aspiration and biopsy, what is exactly bone marrow? So the first question is, what is most common site for bone marrow examination? These are very simple questions. Can sternal aspirate can be done in children? What are the contraindication of bone marrow examination? Can the diagnosis of aplastic anemia be made on bone marrow aspirate only? And what are the condition in myeloid erythroid ratio should not be given? So after the class, you'll see how much we have learned. So I'll be covering my topic under following headings. So what is bone marrow? So bone marrow is a soft spongy tissue which is located in the medullary cavity of the certain large bones. It consists of red bone marrow and yellow bone marrow. Red bone marrow contains hematopoietic stem cells, giving rise to red cell, platelet, and granulocyte. Yellow bone marrow is made up mostly of fat, and it contains stem cells that can become cartilage, fat, or bone cells. So why do you want to see this bone marrow? So what are the indication of bone marrow? So there can be hematological indication and non-hematological indication, as sir mentioned initially also. So hematological, most of the marrows, like 80% marrow, we do it for hematological indications. It can be because they are basically because of unexplained anemia, unexplained thrombocytopenia, neutropenia, any kind of cytopenias. Then in the diagnosis of when we are seeing something in the peripheral blood smear and we want to confirm it on bone marrow biopsy or bone marrow aspiration, of leukemias, myeloproliferative neoplasms, MDS, myelomas. So these are all hematological conditions, or lymphoma. In lymphoma cases, it is also done for bone marrow. It is also done for staging of the disease. If anything which is present in the bone marrow, it straight away goes into stage 4. And we also do it for follow-up status of chemotherapy. As we know, for induction chemotherapy, in both in ALL or AML, after 1 month, there is a marrow with, to see what is the remission status of that patient. For non-hematological purposes, the first foremost common thing for which bone marrow is asked for is pyrexia of unknown origin. To look for collecting cultures for, in these cases only, pyrexia of unknown origin. To look for parasites, storage diseases, metastasis, and staging. So how to see that? Before that, we'll see that why do we require bone marrow biopsy? Because bone marrow biopsy is a painful procedure, but we have to do it. So one interesting thing I want to say about this Trephine word came for trepan. 3500 BC, this term is a Latin word derived from trepan. And it was, at that moment, it was known as a cylindrical object to drill out the what do you call this? I mean, scalp tissue, the head. For certain CNS disorder, they used to do it. But later on, it was seen that we can take out the bone marrow from this instrument, and that's how the history goes for bone marrow Trephine biopsy. So why we require Trephine biopsy? So when we aspirate the blood, the arrangement of cells is lost. So if we have to look the arrangement of the cells, then we definitely need the word for that arrangement of cell is known as topography. So if we need to look for arrangement of cell or topography of cell in bone marrow, we need to do a bone marrow biopsy. Like in certain cases, we see abnormal localization of precursor cells or LAIP. For that, we need bone marrow biopsy. In cases where we do not get sufficient amount of aspirate or dry tap or clotted aspirate. Then in the definition of aplastic anemia, it is written that the diagnosis of aplastic anemia is made when there is cellularity is less than 25% in bone marrow biopsy. So in diagnosis of aplastic anemia, we need bone marrow biopsy. To look for marrow fibrosis in cases of myeloproliferative disorders. And for metastasis, again, in metastatic, because there are clusters of cells, so they do not get aspirated in bone marrow aspirate. And in certain granulomatous diseases also, we do not see cells in aspirate. So in those cases, we require bone marrow biopsy. So how to do it? The technique. So first of all, the site. The most common site is posterior superior iliac spine. I'll discuss what are the advantages of this site, but how to approach this site, how to make this site visible. So patient can be lie down in a prone position. That is the most comfortable position, as you can see in this picture, because the prominent part of the pelvis, that is your iliac crest, become prominent, and we move medially and just lateral to the spine, we have the iliac crest, from where the aspirate has to be taken. We also, in certain patients, we also do in a left lateral position or lateral decubitus position. Left lateral isliye because most of us are right-handed, so it is easier to do it. So in this position, the patient is made to lie in a lateral position, left lateral position. His the top feet is made to touch his chest, and the lower feet is made to lie straight, just to make prominence of this iliac crest. And this is your posterior superior iliac spine, just adjacent to the dimples which are seen at the posterior part. So what are the advantages of this site? Advantage is there is good amount of marrow tissue in iliac crest, and PSI is superficial and fairly movable landmark which can be palpated and located easily. The thickness of cortical bone is lesser on PSIS as compared to other parts of the iliac crest, and the thickness of iliac crest blade is more, so we can get a good quality of marrow biopsy, and there is fixation is very good at this position. It is slightly less painful, however all the bone marrows are painful, so it is slightly less painful as compared to the other side. So what are the other, and the one advantage which is very important, that we can take aspirate and biopsy from the same site. So what are the other sites? These are less common sites like sternum and tibia. In sternum, the space is between second to third intercostal space and just lateral to the midline. But sternal aspirate should not be attempted in less than 12 years of age. And the other thing, we cannot take biopsy from this site, and it is, patient becomes more apprehensive because he can see all the procedures going on in front of his eye. So this to us, it is not a preferred site. In our setting, we don't usually do it. The other site in infants is tibia, because red marrow is preserved over there. Just below the tibial tuberosity is the site for bone marrow aspirate. Again, bone marrow biopsy cannot be done from this site. So because we in our practice are doing bone marrow biopsy in almost all cases, so we don't prefer these sites. We prefer posterior superior iliac spine. So what are the prerequisites before going to obtain the bone marrow? So we need disinfectant, it is alcohol-based spirit, povidone iodine or betadine. Then for anesthesia, we use 2% lignocaine, syringes, just to aspirate, just to push the anesthesia to take out the bone marrow aspirate, or if we have to collect sample for flow cytometry or cytogenetics, so at least minimum of 3 syringes are required. Then for instrument, we need both aspirate and biopsy needle. Smears ke liye we need slides. Then for, if we are collecting samples for flow cytometry, EDTA, if we are collecting sample for cytogenetics, then heparin vial. If we, in a suspected case of PUA, we have to collect samples for culture, then culture bottles, and tincture iodine and adhesive tape is for sealing the wound. So bone marrow aspirate needle, these are basically known as Sala's needle. They can be of metal or they can be disposable. Initially, we were using a metal needle in our setting, but now we have shifted to disposable needle. Advantage is that because these needles are reusable needles, but they have to be autoclave. If you in your setting there is a doubt that autoclave is not functioning properly, kindly do shift to bone marrow disposable needles. And this is the place where number is written. For children, we are used for children the 18 gauze number bone marrow aspirate needle is used, and for adult number 16 is used. For bone marrow biopsy, Jamshidi needle is used. Again, it can be of metal or disposable. It has 3 parts: the main needle, then we have stylet, and then this is called obturator, just to push out the bone marrow biopsy when it is done. For children, number 13 is used. For adult, number 11 is used. So what is the procedure? So before going to the procedure, the person who is doing bone marrow need to wear necessary PPE kit. It doesn't mean that he has to fully cover himself with a PPE kit, but the necessary is like disposable gown just to avoid the spill of the blood, gloves. Then he need to check the needles, the slides, stylets, and the plastic syringes. Sometimes what happens that when we are into the bone marrow and we are collecting the sample and the plastic syringes is not fitting. It's not fitting the syringe. So adequate pressure is not maintained. So these things has to be checked prior to the procedure. Then consent from the patient. It is very important because it's an invasive procedure. So consent from the patient has to be taken. And patient has to made lie in a prone position or left lateral position, as I told you earlier, with top leg flexed or knee chest position, we say it, and the lower leg straight. The PSIS is located, the most prominent part of the pelvis, and moving medially just adjacent to this dimple. Okay. The chosen area is cleaned with alcoholic wipes followed by povidone iodine. For anesthetizing, 2% lignocaine, 5 ml quantity is used, and we anesthetize from inside. Like we will anesthetize the skin, subcutaneous tissue, underlying muscle, and periosteum. And a minimum of 1 centimeter perimetry of that marked area has to be anesthetized. So for procedure, the bone marrow needle with the stylet has to be pushed on the skin, perpendicular to the skin, and gently advanced into the periosteum. When the needle pierces the periosteum, it gives a giveaway feeling. The resistance is suddenly lost. At this moment, patient will complain of pain. That means you are into the bone marrow cavity. Now we will advance a little more and the needle will be fixed. Like you can see in this picture, the needle is fixed. They have not touched the needle, but needle is fixed into the bone marrow cavity. Now we will remove the stylet. We'll remove the stylet and we'll attach a syringe and will suck the blood only to fill the hub of the syringe. Only to fill the hub of the syringe. That is only 0.2 to 0.3 ml of bone marrow has to be aspirated for slide making. Otherwise, we'll make it dilute with the peripheral blood. And these has to be transferred to the technician or your colleague whosoever is assisting in your bone marrow procedure. If the sample for bone marrow, if the sample for flow cytometry has to be collected, then a different syringe has to be attached to this and samples are to be collected. So initial syringe in which we collected the sample for bone marrow, this has to be directly transferred onto the slide and has to be tilted just to draw the excess blood to drawn off. And there are two methods of slide formation. One is like we make a slide, like we make a blood film. So for that, we'll put that blood drop on a side of the slide and we'll spread the slide as we spread for normal blood smear. And for squash, we'll put that one drop of blood on the middle of the slide, and with the different slide, we'll spread it like we make a cytology smear. So there we can make two types of smears: wet smear like we made it for the blood smears, and squash smear like we made in the FNA smears or cytology smears. Again, if bone marrow biopsy has to be done, then the same point has to be, the same point, incision point has to be used for in advancement of Jamshidi needle. But when we go inside the periosteum, it has to be a slightly different from the aspirate side. Otherwise, your biopsy will show hemorrhage. Now we'll move with the twisting movement. We'll advance inside, and when similarly as we did in the aspirate, when we are into the periosteum, it will give away feeling. Again, patient will complain of pain, and when we are in the bone marrow, we'll take out the stylet and we'll rotate it. We'll rotate it 360 degree in both the direction because we are taking out biopsy. So we need to separate it, or we need to cut it from the surrounding tissue. Otherwise, we'll not get that biopsy. So it takes force actually. Okay. And with experience, we know that adequate amount of biopsy length has been taken. Though also this bone marrow, the PSIS is a very safer site to collect the biopsy. We get a very adequate number of very large size of bone marrow biopsy can be obtained from this site. Then we will move with the slight twisting movement. We will remove the needle, and sterile gauze will be kept on that and has to be pressure has to be applied for several minutes until the bleeding is stopped. But we don't have to seal that site till now before we examine that biopsy. So this biopsy specimen which is extracted, we will take out with the obturator, which I showed you in the earlier slides, from the distal end. There is like some people say it should be pushed from the proximal end because proximal end is narrow, so biopsy gets crushed if we pushed it from the distal end. But I don't know, it is easier to push from the distal end. And in Bain also it is written it should be pushed from the distal end. So biopsy, when we'll check that it is adequate, like in some cases we might not get adequate biopsy, like in myeloma cases, the bone becomes very fragile, we get very small biopsy. Or if we see that it contains only white material, that is cortical bone, or glistening tissue, that is cartilage in cases of children, then we need to attempt a second biopsy from a different needle. If it is adequate biopsy, then we'll make imprint smears, touch imprint, and roll imprint. Roll imprint is when you roll the biopsy on the slide, and touch imprint when we are touching the another slide on that biopsy. And then the biopsy has to be transferred into formalin for fixation. So we have taken out the aspirate, we have taken out the biopsy. Now that wound site has to be, pressure has to be applied, a firm pressure has to be applied. And once the hemostasis is achieved, it has to be sealed with tincture iodine, a bandage should be applied, and patient should be instructed to lie supine for 30 minutes. The area has to be kept clean, bandage has to be removed after 24 hours. The wound site to be checked for signs of injuries, signs of infection or hematoma formation. And in cases of thrombocytopenia, pressure may be required. It's a very safe procedure and hardly complication occurs, but we do see complications like post-operative bleed, persistent pain, infection, and sometimes breakage of needle in cases of very fibrotic bone or osteopetrosis. It's a disease in which there is no medulla, there is only cortical bone. So we do see these cases. Contraindication for bone marrow aspiration and biopsy as such, there is no absolute contraindication, but bleeding diathesis is a contraindication, and in these cases, if bone marrow aspirate or biopsy has to be done, then the patient has to be given certain kind of treatment, like if it's for the thrombocytopenia, platelet transfusion may be done, or for like factor assays, factor deficiency, patient should be given fresh frozen plasma, and then the aspirate should be done if required. Local site infection, suspected osteomyelitis, because we'll spread the infection to other sites. So coming to the staining part. So as we can see in the lower picture, these are the, like, we have seen all kind of smears, like A particle if there are no particle. Then there's hemodilutions or slight coagulated bone marrow is also seen. Then this smear contains scant particles. This is like fat, greasy. This can be because of the, as such, in cases of aplastic anemia also, or from the greasy slides also. And these are the fairly good slides. So whenever bone marrow slides, bone marrow has to be seen, it should always be provided with the peripheral blood smears. One peripheral blood smear, 2 bone marrow aspirate smears, and 1 imprint smear. These are minimum. Staining is done with Romanovsky stain, basically with MGG or Leishman, whatever is available at your place. And in some cases, we do require special stain. In cases, if our aspirate is showing acute leukemia and we are suspecting myeloid leukemia, then MPO should be done. NSC in cases of we are suspecting M5, and Pearl stain in cases if we are like suspecting iron deficiency anemia or for myelodysplastic syndrome. So how to interpret? So initially the marrow has to be, the smear has to be evaluated on low power or scanner view for particles, whether it is particulate or not, whether it is diluted. For cellularity, like as a rule, as a journal rule, remember this thing, it is like, it's a rough rule actually, 100 minus age. Like if we are examining, if it's a 20-year-old male, then his normal cellularity will be 80%. But anything which is more than 90% is hypercellular, and anything which is less than 10% is hypocellular. Okay, so roughly the cellularity. Then on low power, we have to look for megakaryocyte for their adequacy and for their any kind of dysplasia. And adequacy in terms of like the normal adequacy of megakaryocyte is 3 to 5 per particle. Okay. Anything less than that is like decreased megakaryocyte. For dysplasia, also we need to for dysplasia we need to see at least 30 megakaryocyte to comment upon dyspoetic megakaryocyte. Then moving on to higher power, a well-spread area is selected for studying the morphology and to do the marrow nucleated count. At least 500 marrow nucleated cells should be counted. And this is normal myelogram. This is our normal myelogram. Like it consists of 1 to 4% of blast or promyelocyte, roughly equal amount of myelocyte, metamyelocyte, and majority of neutrophils. Then erythroblast consists of 20 to 30%, lymphocyte 5 to 15%, and plasma cells 1 to 3%. This is a report prototype, what we dispatched from our institute. Like it mentioned, as I mentioned you, peripheral blood smear is necessary. So we give a peripheral blood smear finding. Then bone marrow has to be evaluated, and these all points has to be written on the report. Like what is the cellularity? What is megakaryocyte? Are they adequate? Are the morphology normal? Or there are dysplastic or micromegakaryocyte or immature forms. What is ME ratio? Myeloid erythroid ratio. Myeloid erythroid ratio, the normal ratio is 3:1. It ranges from 3:1 to 15:1. Then granulocytic precursor, erythroid precursor, what is morphology and their maturation, whether any shift is seen or dysplasia is seen. Lymphocyte for percentage, for number, and for abnormality. Similarly, plasma cells. Any other abnormal cells, parasites, fungus, like histiocytes, if they are seen in increased number. If there is any evidence of granuloma, that has to be mentioned. And lastly, the marrow nucleated count has to be mentioned. And based on this peripheral blood finding and bone marrow aspirate finding, we issue a final impression. And if we require that bone marrow trephine biopsy is required for the confirmation, so we do note a line under the report. One line about ME ratio, myeloid erythroid ratio. Like myeloid erythroid ratio consists of ratio between myeloid and erythroid. But if any cell line apart from this is raised, like plasma cells, lymphocytes, then we should not give any ratio. Okay, so that was a question in the pre-test. Few lines about the special stain. The pearl stain it is done for iron stores, and there is a grading on aspirate by Gale et al., in which I'm not going into detail. 0 to 1 is suggestive of iron deficiency, and they look like these blue dots, blue-green dots in the particles. And 2 to 3 is your normal store, and 4 to 6 is iron overload. We do require pearl stain in cases of myelodysplastic syndrome to see these beautiful ring sideroblasts. These ring sideroblasts are seen in erythroid precursors, and these cover more than 1/3 of the periphery. And 15% are the significant number. Some other special stains are required as if, like when we see the aspirate and we see like some granulomas are visible and we need to check it. So we can order a special stain like Ziehl-Neelsen stain for acid-fast bacilli, or pass for some kind of, like if you are looking for any, like this is adenocarcinoma net. So we wanted to confirm that it is adenocarcinoma. Then if it is leukemia, we need to confirm it on, we need to look for these immunocytochemistry for myeloperoxidase and Sudan plaque. But these are required when we see our smear, our Leishman smear or MGG smear, and if we suspect that we require it, then we order it. There are certain limitations to bone marrow aspirate, like in cases of acute promyelocytic leukemias, when we because of there is a coagulation abnormality in acute promyelocytic leukemia because of high tissue factor, it clots. It clots before we draw the smear. So we get very poor smear in cases of APMN. Similarly, in myeloma, we get very poor smear because of hypergammaglobulinemia, these smears, when we take out the sample, it clots immediately. So we have to be very cautious in these cases while making the smear, or otherwise we should always do a bone marrow biopsy along with this. Then there are cases in which we get dry tap, like in cases of fibrosis, in cases of like packed marrow in cases of acute leukemia, then hairy cell leukemia or osteopetrosis. Coming to the bone marrow biopsy processing, like we took out the bone marrow biopsy and we put it into the fixative. Then it has to go for decalcification, and like any histology tissue, it has to be paraffin embedded and section has to be cut. If required, then special stain for reticulin or immunohistochemistry has to be applied. For fixation, AZF, that it stands for glacial acetic acid, zinc, chloride, and formaldehyde. It is made into the distilled water, and the biopsy is transferred into these aliquot for 24 hours. Next day, the biopsy is washed with distilled water for 30 minutes and is transferred to decalcification fluid, which is 10% formal formic acid. Then it is left for decalcification, and depending on if this decal solution is recently formed, then it takes less time. If it has been taken a slightly longer time, that it takes more time. Then after being decalcification done, it has to be embedded in the paraffin bags, similar to the histology specimen as we do for other histology specimens. Then sectioning, 1 millimeter thick sections are cut from the paraffin wax block. The sections are stained with hematoxylin and eosine and reticulin stain. And additional slides or sections are ordered when required for immunohistochemistry as necessary. What is written in Barbara Bain is like 20 section, 5 section per slide at different levels to be taken. But I mean, we are not doing it as per now, but it is written in the literature. So we have to learn this thing, that 20 section at different level has to be taken, 5 sections at one slide. H in section should be examined at low power, similarly like aspirate, for adequacy of the biopsy. For adequacy, it is written like 2 to 3 centimeter length after processing is an adequate length, containing at least 6 IT spaces, intertrabecular spaces. So for low power, the biopsy has to be examined for adequacy of the biopsy, for detection of any focal lesions or focal infiltrate of lymphoma cells or carcinoma cells, for bone structure, for megakaryocytic number. Moving on to higher power, it should be basically the bone marrow biopsy is done for looking for topography, for location of cells and arrangement of cells and their proportion. So that has to be looked after at the medium power, for nature of any focal lesion and for assessment of blood vessels. For higher power, finer details in cases of fungal or protozoal infection has to be looked for. So coming on to the normal topography of hematopoietic precursor in the bone marrow biopsy, as we can see in this section, this is our cortical bone, and the subcortical intratrabecular spaces have very low cellularity. And these are the trabeculae. And between the trabeculae, we have this intertrabecular space. And these are the cells we are interested in. This is the area we are interested in. If we look at the higher part, like this paratrabecular area or endosteal zone is the area where immature myeloid precursor lie. And when they mature, they move on to the intermediate zone or the central zone. So in the central zone or intermediate zone, we find erythroid precursor and our matured myeloid precursor. Near the sinusoids, we find megakaryocytes. So this is the normal topography of the hematopoietic precursor in bone marrow biopsy. And this is a prototype which we dispatched in our setting. It has to mention the gross for the size of the biopsy. Then low part examination for number of intertrabecular spaces. Like if it is less than 6, it is inadequate. For cellularity, for number of megakaryocyte and their arrangement, whether they are seen in cluster, whether there is any dysbiosis. In cases of ET or myeloproliferative disorder, we see clustering, pleomorphism. So that has to be mentioned. Then topography and maturation of granulocytic and erythroid precursor. Any abnormal infiltrate, or if any special stain has been done, then it should also be mentioned in the final report. And it should always be examined with aspirate. And based on the aspirate and bone marrow biopsy, a final impression is issued. So these are a few examples how Dr. Rashmi will be dealing the cases in detail. I'm just showing that this is a gross bone marrow biopsy, which can see it's a very red appearing. So on like aspirate is what? Megaloblastic erythroid hyperplasia. Like in bone marrow biopsy also, we can see these immature erythroid precursor. And compared to this, this is a case of, like this biopsy is taken from a CML patient, and it shows it's not that red like this case. So it is basically myeloid precursor. So sometimes we do get a impression from the bone marrow biopsy also, from the gross picture also. Like in cases of aplastic anemia, we can see a very yellowish greasy biopsy. In cases of myelofibrosis, this is a dirty looking biopsy. Similarly, like this is a myxoid kind of biopsy, and the bone marrow biopsy ultimately showed gelatinous transformation. And this is like myeloma case in which we can see these lytic areas grossly also. Though I haven't seen this much long bone marrow biopsy in myeloma cases, because in myeloma the biopsy becomes very fragile. So we do get some idea from the bone marrow, the cross examination of the bone marrow biopsy. Few lines about the special stain on the bone marrow biopsy. Reticulin is one of the important stain which we required in all myeloproliferative neoplasms in which we are suspecting that fibrosis might be there. So reticulin has to be done. The grading is done. This 0 to 3 grading is according to European classification. And in some cases, if we required, immunohistochemistry is advised. Like this is a case in which last cells were seen. Patient was actually evaluated for pancytopenia. But on bone marrow biopsy, we saw these last cells, and when we applied CD30, these were positive. So this case was like Hodgkin's. These were RS cells which were seen in the bone marrow biopsy. The aspirate was diluted. Similarly, IHC do help. IHC do help in cases of bone marrow biopsy when the aspirate is diluted. But there are certain limitations of bone marrow biopsy also. One thing is it takes time to process. Like in Aspirate, we can see the smear. We have done the bone marrow aspiration in the morning, and we can see the slide in the evening, and we can clearly make out the conclusion. But for biopsy, it takes time, at least 1 week. And sometimes the artifact, crushing artifact may be there because of poor technique, which may limit the diagnosis. So that's all from my side. And I'm sure now we'll be able to answer the questions which were there in the pre-test. Thank you. Any questions? Somebody from the chat section, I can see, please tell me about how to comment on the ME ratio. So ME ratio has to be commented when there is proliferation of myeloid and erythroid. See, this is ME ratio, myeloid to erythroid ratio. If anything which is other than myeloid to erythroid is proliferating, then we need not to give ME ratio. And for ME ratio, we need to count 500 cells. 500 cells, and based on that, myeloid erythroid ratio is given. If there is a dry type, how to report it? For dry type, we cannot do anything. We have to give report as a dry type. Only we have to wait for the biopsy actually.
Okay. So after an approach to the bone marrow aspiration and Trephine sections, I'll be discussing few important cases here, which will give you an idea how to interpret the aspiration followed by Trephine biopsy. At the outset, I would like to thank Dr. Neeraj Jain for giving me an opportunity to be a part of Melap Pathology Update. Here, I want to say one thing, that most of the images, microphotographs that I will be showing are from the routine practice that we get in the cases day to day. However, few microphotographs are taken from the internet. So I'll be presenting my presentation under the following headings. I'll be discussing the cases that can present with pancytopenia. I'll be discussing certain reactive changes in the marrow, the myeloproliferation, the MDS or MPN syndromes, cases with infectious etiology, and leukemia. So one thing I would like to say, that bone marrow aspiration must always be accompanied by a good peripheral smear, a CBC, a bone marrow imprint slides, as well as the Trephine section. All these are mandatory for the complete evaluation of a case. So before going ahead with a bone marrow aspiration and biopsy, we have to take the history in detail. The history must include the onset of symptoms, the duration of the symptoms, the age of the patient, because many diseases have a predilection for a specific age group, whether there is any family history present or not, any previous treatment or drug exposure. Drug history is very important because certain drugs can cause specific changes in the marrow. History of chronic alcohol abuse, history of dark colored urine, especially if we are thinking about the paroxysmal nocturnal hemoglobinuria, and history of any associated bleeding. We have to examine the patient for the presence of any organomegaly, any significant lymphadenopathy, any mass, whether in the mediastinum, intra-abdominal or retroperitoneal, presence of bone tenderness or bleeding. So initially, I'll be discussing all the cases which can present with cytopenias. So what is a cytopenia? Cytopenia is reduction in any of the three cellular components of the blood. Either this cytopenia can be unilineage when it involves one lineage, or can be bilineage, or it can involve all the three lineage. So this is just the definition. Hemoglobin of less than 10 gram per deciliter in females and less than 11 gram per deciliter in males, with absolute neutrophil count of less than 1,500 cells per cubic millimeter and platelet count of less than 1 lakh per cubic millimeter to classify a case to have a cytopenia. So coming to the first case, 17-year male presenting with malaise, tiredness, weakness. On examination, he has pallor but no organomegaly. And we can make out the characteristic tongue appearance here, the glossy tongue. This is the characteristic knuckle pigmentation that is seen. So history along with the physical examination. Then we made a peripheral smear. In the peripheral smear, the striking feature is the presence of a hypersegmented neutrophil There is definitely cytopenia because the number of WBCs are also reduced. We can see presence of macrovalocytic cells, the macrocytic cells, presence of transfused, fully hemoglobinized RBCs. This is the CBC, which is showing the hemoglobin very less, 2.6, and the MCV is raised. In this RBC histogram also, we can see a right shift of the curve. And this is the RBC scattergram, where we can see the right and the upward shift of the RBCs. These are certain images. We see the hypersegmented neutrophil, the Jan band form. This is again the Jan band form, presence of occasional nucleated RBCs. Again, the hypersegmented neutrophil, the macrovalocytes, and clearly the platelet count is reduced. This image is showing the basophilic stippling, presence of certain teardrop cells, and the transfusion-associated fully hemoglobinized or microspherocytic cells. Now, coming to the bone marrow here is clearly showing the erythroid hyperplasia, and most of the erythroid have this megaloblastic appearance, that is nuclear cytoplasmic asynchrony. The cytoplasm is almost matured, but still there is a big nucleus. We can see some mitotic figures here. This is a macropolycyte, which is seen here, and the erythroid hyperplasia. This is the Trephine section of the same case. The erythroid precursors are increased in number, and they are seen in the clusters. So this is a clear-cut case of megaloblastic anemia. One thing I want to pinpoint here is that megaloblastic anemia can be diagnosed by complete blood count and a careful examination of the peripheral blood smear associated with serum vitamin B12 and folate level. Bone marrow examination is not indicated in cases of megaloblastic anemia. We proceed ahead with bone marrow examination only if the patient has unresponsive anemia, not responding to the B12 and folate injections or any other hematinics. So when we are suspecting MDS, especially in the elderly people, then we proceed with the bone marrow examination. This is a case 2, 10-year girl with pallor and weakness, and she had petechiae all over the body. This is a peripheral smear. There is marked pancytopenia. I can see only 2 lymphocytes here. The hemoglobin is markedly reduced. WBC count is also reduced, and the platelet is also reduced. This is a particle in the bone marrow aspirate, which is clearly hypocellular and shows only fibrofatty particles. And as I told you that we always do a bone marrow imprint, the touch imprint as well as the roll imprint with the Trephine biopsy that we obtain, so that the touch imprint can always be accompanied with the bone marrow aspirate slide. The touch imprint is again showing the increased number of fat spaces and very less hematopoietic precursors. One of the students in the previous lecture had asked, what do we do if there is a dry tap? So to answer that, this imprint smears are very important in that cases. Even if the aspirate is diluted or aspirate yields a dry tap and you have obtained a biopsy, always make a touch imprint. So if there is no aspirate available because of dry tap or dilution, you can get an idea with the help of the touch imprint and the roll imprint. So these are very important. When we got the Trephine biopsy, there is only fat spaces with almost loss of the hematopoietic precursor. Occasional cluster of these lymphocytes are seen. So these lymphocytes in the aplastic anemia are the T lymphocytes, and these T lymphocytes can at times be very reactive, especially when you're seeing a large number of lymphocytes in the aspirate, in the hypocellular marrow. These reactive lymphocytes can at times give a very atypical appearance. So there is a caution while interpreting the biopsy. For diagnosis of the aplastic anemia, the adequate length of the biopsy is a must. Ideally, 1 to 2 centimeters of the biopsy must be obtained. You can get other foci of the residual hematopoiesis in the biopsy. The aplastic anemia is an ongoing process. It does not happen overnight. So in these patients, we might get focal areas of residual hematopoiesis. Now, why is it important to understand this is that while doing aspirate, if our needle goes and hit in these areas where there is residual hematopoiesis, we might get a normocellular or slightly hypocellular aspirate. So by just looking at the bone marrow aspirate, we will say that, okay, this case has a normocellular marrow, but the peripheral smear had pancytopenia. Hence, it must always be accompanied with a trephine section. The trephine section will give a clear-cut clue about the entire process that is happening in the marrow. Some places, some intertrabecular spaces will be hypocellular, some will be totally have only the fat spaces, some will have only some foci of the residual hematopoietic precursors. So trephine biopsy is must if we are suspecting aplastic anemia. Moreover, trephine section is required to differentiate aplastic anemia from hypoplastic MDS or from the patients who have marrow fibrosis where the aspirate is inadequate. And if these certain clusters of lymphocytes, which are usually T-reactive, as I told you, if they have a like very atypical morphology, we can proceed with the IHC in these cases with CD34. So ideally 0.5 to 1% is the normal CD34 positive cells that we get. And it is less than 0.3% in aplastic anemia cases. And in hypoplastic MDS, these 34 positive cells will be increased. Now, this is a third case, 10-year female with fever and splenomegaly and lymphadenopathy. This is a peripheral smear. Clearly, there is cytopenia, but certain atypical looking, the blast looking like cells were there. The bone marrow was done, which was also aparticulate, markedly diluted smear we got, and it showed presence of these blast-like cells. So we proceeded ahead with the trephine section. And when we got the trephine section, as you can see, it is full of all these cells, which are very hyperchromatic of small size. We cannot see the normal hematopoietic precursors, including megakaryocytes in this. So this was a case of acute leukemia, which is presenting with a what we used to call it as aleukemic leukemia or subleukemic leukemia. So in these cases also, the trephine biopsy is very helpful for diagnosis. This is the next case, a 30-year-old female presenting with fever, oral ulcers, chest pain since 1 month. On examination, she had pallor and mild splenomegaly. These are her biochemical parameters. Clearly, the CBC showed pancytopenia and peripheral smear showed 4% blast cells. This is a peripheral smear showing the hypersegmented neutrophil, a pseudopelger form indicating the dysplasia. Here we can make out certain blast cells. And here again, we can see certain blast looking like cells here. So the bone marrow aspirate was done. Bone marrow aspirate is showing increased number of blast cells. There is dyserythropoiesis, that is binucleated and trinucleated erythroid precursors. This is a dysplastic megakaryocyte. Here again, presence of blast, certain amount of dyserythropoiesis. This is a cluster of erythroid precursors showing the megaloblastoid changes as well as the binucleation and multinucleation, which shows dyserythropoiesis. This is a dysplastic megakaryocyte. This is a macropolycyte here, and these two are imprint smears. In imprint smears, clearly we can see the clustering of the blast cells, the dysgranulopoiesis, presence of the ringed nucleus, the erythroid precursor showing the left shift. So clearly we can see although this patient had peripheral cytopenia, but the imprint and the aspirate were normocellular to slightly hypercellular. And it was associated with trilineage dysplasia and presence of 17% blast when we did the 500 nuclear cell count. So now, by now we have an idea that we are dealing with the myelodysplastic syndrome. And as per the newer classification, it is now put into the increased blast 2 category. Earlier, we have to have this MDS with excess blast 1, excess blast type 2. So in the recent classification, WHO, the MDS has been further reclassified into MDS with increased blast type 1, MDS with increased blast type 2, etc. This is a trephine section that we got. And as the Dr. Geeta has explained you, in the paratrabecular area, normally we get 2 to 3 cell layer thickness of the immature granulocytic precursor, and megakaryocytes are usually present in the center in the intertrabecular area around the sinuses. But here what we see? Here we see the clustering of the megakaryocytes in the paratrabecular areas. So clearly this shows that there is some loss of the architecture, loss of the normal topography, and then evidence of dysplasia. Here we see the clustering of the megakaryocytes. Similarly, if we find the clusters of the erythroid precursors in the paratrabecular area, that is also considered to be a sign of dysplasia. This is a Trephine section. Usually the blast and the promyelocytes, they come to line the paratrabecular area. But in the intertrabecular areas, if we see the clusters of blast cell or increased number of blast cell, this is definitely abnormal and evidence of dysplasia, and these cluster of blast cells are called as abnormal localization of immature precursors. So clearly, this case has distortion of the normal topography, dysplastic looking megakaryocyte, dysplastic erythroid precursors. Finally, we proceeded with the CD34 immunohistochemistry stain, and you can make out the 34 positive cells are clearly increased in this case. So this is a case of myelodysplastic syndrome with increased blast 2. So in cases of patients who are elderly, in beyond 4th or 5th decade, have anemia with cytopenia, and if they are not responding to the normal hematinics, we must proceed ahead with the bone marrow aspiration accompanied with a imprint smears and Trephine biopsy, and if required IHC. And we must always remember to do a bone marrow pulse stain, bone marrow iron stain, to check for the presence of ring sideroblast, because that will classify the case entirely into a different category. This is the next case, 40-year female with fever, cough, and cervical lymphadenopathy. Ideally, whenever we proceed with the bone marrow, so before the procedure, we ask the patient to get all the viral markers done. And in that, we noticed that this patient was reactive for HIV and she had a low CD4 count. Peripheral smear showed cytopenia and her bone marrow aspirate was done. Bone marrow aspirate looks normocellular, but one thing that is quite striking here is the presence of increased number of plasma cells. We can definitely see that this is a binucleated plasma cell, and otherwise the plasma cells are slightly increased in number. So the Trephine biopsy was also done. And when we got the Trephine section, we see a clear-cut bone marrow granuloma here. So this patient was immunocompromised, had cytopenia in the peripheral smear, aspirate showed the reactive changes in the form of plasmacytosis, and the Trephine section is showing the presence of granuloma. Two things which are important to notice here is that increased number of plasma cells in the bone marrow aspirate could be because of the reactive changes, and increased plasma cell does not always mean that the patient has plasma cell myeloma. So we have to check for the clonality of cells. We have to, before clonality, we have to take the proper history, and we have to rule out the reactive plasmacytosis. So this reactive plasmacytosis can be can be seen in HIV infections. And in many patients, I have seen the reactive plasmacytosis of up to 40 to 50% marrow-nucleated cell count. So it can be up to that much. So just because the plasma cells are more than 10%, we don't classify the case into the myeloma. We have to check for the clonality, and we have to check whether it is monoclonal or polyclonal plasma cells. So we have to proceed with the serum protein electrophoresis and immunofixation. And this case showed presence of granuloma. Now these granulomas are usually not seen in the aspirate smear, because whenever there is a granuloma formation, it is surrounded by fibrosis. And in the aspirate, these granulomas don't come that easily. So to check for the presence of granuloma, the Trephine biopsy is must. So in any patient who is immunocompromised, any patient of pyrexia of unknown origin, or if we are suspecting tuberculosis, we have to do the Trephine biopsy in them. So diagnostic pitfall, as I explained, is that infective etiology can give rise to increased plasma cells in marrow, and these are polyclonal in nature. Even in fact, in cases of LD bodies, Leishmania, Donovan, there also I have seen increased number of plasma cells. This is the next case, 39-year male with fever, anemia, and splenomegaly. Peripheral blood smear and CBC showed pancytopenia, and these are the indices. The retic count was less than 1%. This is the smear, and needless to say that it is very clear-cut that the macrophages or the reticuloendothelial cells are seen in increased number. And most of them are showing the hemophagocytosis. Here we can see the erythroid precursors are engulfed. Here we can see one granulocytic precursor is also engulfed. Here also the phagocytosis. So as Dr. Geeta has also explained, while interpreting the bone marrow aspirate, along with all the three lineages, we have to check whether the macrophages are present in normal number or whether they are increased. If they are increased, whether they are normal looking or they have certain phagocytic substance or they have certain morphology suggestive of any storage disorder. So it is very important and critical to examine the macrophage morphology in the bone marrow aspirate. And like Barbara Bain has clearly said that if these phagocytic macrophages are more than 1%, it should be reported in the our bone marrow aspirate report. So this was marrow showing hemophagocytosis. And this is the Trephine section. Like we can see the macrophages are present in increased number, and most of them are showing presence of these phagocytic elements. So whenever we see marrow hemophagocytosis, it has to be reported in the bone marrow report, and it should be conveyed to the clinician because at times the hemophagocytosis can be very fatal. We have to ascertain the cause, whether it is reactive or malignant in nature. The reactive phagocytosis can be seen in patients with autoimmune disorders like in rheumatoid arthritis, in patients like following the viral infections, following bacterial infections, following certain drugs, following any long-standing illness, in cases of leukemia, lymphoma, any solid malignancy. So we have to, must try to reach to the cause of the hemophagocytosis. In recent outbreak of the COVID pandemic, like while this second wave of the pandemic was going on, after that, we received many cases for bone marrow examination who had pancytopenia in the peripheral smear, and marrow was showing massive hemophagocytosis. So this is just one slide about the diagnostic criteria of the hemophagocytic lymphohistiocytosis, where there are 8 criteria and at least 5 must be present to classify the case into hemophagocytic lymphohistiocytosis. Coming to the next case, this is 35-year male with fever and splenomegaly, and again the pancytopenia, but the marrow was normocellular. But yes, what do we see here? This is again increased reticuloendothelial cell and something inside these RE cells, a dot and a comma-shaped structure. So all of you must be knowing this is a typical appearance of the Leishmania Donovani body. This is the Trephine biopsy. Here again we see a macrophage with these LD bodies inside. So this patient had bone marrow leishmaniasis, and this leishmaniasis can also give rise to the reactive changes in the marrow, like increase in the plasma cells in the marrow. The peripheral smear will show monocytosis. So from the peripheral smear, from the CBC, from the bone marrow aspirate, by looking at all the lineage of the cell, we must try to pick up the clue regarding what is happening in the marrow. Next case is a 5-year male child with anemia and weakness. This is the peripheral smear showing massive pancytopenia. We can see occasional teardrop cells, a lymphocyte, a neutrophil, almost normochromic, normocytic like blood picture. And this is the bone marrow aspirate. Here we can see these cells, hyperchromatic cells, which are lying in large numbers, and the normal hematopoietic precursors are reduced, and few of these cells are showing nuclear molding. This is the high power view. At focal places, there was clustering and attempt to the rosette formation. This is again the low power view of the particle. Near the particle, we see an abnormal cluster lying here. This is the cluster of these cells showing the rosette formation. We see the neuropil material or the fibrillary material also clearly here. This is the Trephine section. We can see there is diffuse infiltration by these atypical looking small cells. So this was a bone marrow infiltration by a round cell tumor, probably a neuroblastoma. So any solid tissue tumor infiltrating into the marrow can cause peripheral pancytopenia, like what we see here, can cause a characteristic appearance in the peripheral smear, like presence of the teardrop cells, the presence of the nucleated RBCs, or the leukoerythroblastic blood picture that we call as. So this is a case of metastatic neuroblastoma. This is another case where this is a Trephine section showing the infiltration by all these abnormal cells into the intertrabecular areas. See, there are these abnormal metastatic tumor cells which are seen infiltrating into the intertrabecular areas, and there is absolute reduction of the normal hematopoietic precursor. There is loss of topography. I cannot see any normal looking hematopoietic cell here. So this case, we had done the immunohistochemistry with cytokeratin, and these cells were positive for cytokeratin. Although this section has a lot of fibrosis, so the cells are not clearly visible, but we can see the cytokeratin positive cells here. So this was again a metastatic epithelial malignancy in this patient, and further he was taken up for a PET scan and further evaluation. So bone marrow metastasis is quite common, and we get certain evidences in the peripheral smear like presence of teardrop cells, the nucleated RBCs, and these patients can have pancytopenia. These patients can have infiltration into we can see the infiltration into the aspirate smear. And even if there is no infiltration seen on the aspirate smear, biopsy is a must and must always be done if we are suspecting a metastasis. Coming to the case 8, this is 55-year male with weakness and splenomegaly. And bone marrow aspirate was peripheral smear showed pancytopenia. Bone marrow aspirate was hemodiluted, but the imprint smears that we obtained were hypocellular. This is a peripheral smear. We see the teardrop cells, lot of anisocytosis. There is characteristically, we can see all the the WBCs are reduced, the platelet is reduced. We see the presence of nucleated RBCs here. So this is an indication that something is happening in the marrow that has pushed these cells in the peripheral smear, caused the presence of the teardrop cells, lot of anisocytosis, occasional target cell. And this is a Trephine section that we obtained. Definitely the morphology was distorted with some kind of streaming of the cells. Here we obtained, so we processed with the reticulin stain, and this is showing the reticulin stain slide, which is showing the presence of marrow fibrosis. So marrow fibrosis can cause either a dry tap or a markedly hemodiluted aspirate. Hence, I said that the imprint smears are helpful. In such cases, the imprint smears can give a clue. And moreover, we have to proceed ahead with the Trephine, processing of the Trephine section. And Trephine section will be helpful. It will show it, like in this case, it showed the fibrosis and the grade 3 reticulin stain. This is yet another case, 8-year child with retroperitoneal lymphadenopathy. The PBS and the CBC showed pancytopenia, and again the bone marrow was hemodiluted in this child. So when we obtain the Trephine section, we can make out there is total loss of topography. I can't see the megakaryocytes here. They are markedly reduced. I can't see any topographical arrangement here. All I can make out is there is some amount of fibrosis that is going on. This is a closer view, which is again showing some amount of fibrosis. And further examining the other areas of the section, we see these kind of cells, large looking cells, which are definitely not megakaryocytes. These are this is something else that is infiltrating into the intertrabecular areas. The normal hematopoietic precursors are markedly reduced. This is still the closer view. We see these kind of binucleated, multinucleated cells, along with some macrophages in the background and certain lymphocytes. So just to evaluate what are these cells, looking at and this child had, since he had retroperitoneal lymphadenopathy, we thought that we must exclude the Hodgkin's lymphoma because this was associated with a large amount of fibrosis also. So we did CD30 stain, and it came beautifully positive in all these mononucleated and multinucleated large cells. PAX5 was done, and we can see it is weak positive in these large cells. So this was a case of Hodgkin's lymphoma infiltrating into the bone marrow. So if there is a pancytopenia in the peripheral smear, the aspirate is diluted in the Trephine. We must proceed with the Trephine section. Look for the presence of the cells in the Trephine section. Look at the morphology of the cells in the Trephine section. look at whether all the linear cells are present properly, or if they are reduced. If there are abnormal cells present, we have to try to correlate it with the history of the patients, with the clinical finding of the patient, and this correlation will help in a larger extent to reach to a diagnosis. Now, next part of this talk is cases presenting with increased leukocyte count or myeloproliferation. This is a 50-year female presented with fatigue, weakness, and fullness of abdomen. On examination, she had splenomegaly and pallor, and this is a CBC shown here. This CBC, we can see it's characteristically raised WBC count. The platelet count is also raised, 9 lakh. There is presence of immature granulocytes in the peripheral smear. Some amount of basophils are also present. So looking at this CBC, looking at the WBC scattergram. Look at the WBC scattergram here. The WBC count is raised, and we can see a presence of large amount of immature looking cells. So whenever we are interpreting a case in hematology, we have to check everything in toto, right? Like we have to look carefully at the peripheral blood smear. We have to look carefully at all the indices that we see on our CBC report. We have to clearly check the kind of scattergram that we get for the WBC as well as for the reticulocytes, the RBCs, and the platelets. Okay. This is the peripheral smear. The peripheral smear is showing the characteristic morphology, like there is increase in the granulocytic cells with left shift. We are seeing the myelocytes, the metamyelocytes, the eosinophilic precursor is there. This is a closer view showing increased number of basophil. This is a eosinophil, a myelocyte, and certain amount of dysplasia. This is the bone marrow aspirate, which is characteristically showing the granulocytic proliferation with some amount of left shift, the presence of megakaryocytes, which are slightly hypolobated. We call them as micromegakaryocytes. This is a characteristic C blue histocyte that we described in cases of CML. This is again a closer view showing the increased granulocytic cell, the presence of the dwarf megakaryocytes, the abnormal looking megakaryocytes, increase in the eosinophilic precursors as well. And this is the Trephine section, which is again showing a hypercellular Trephine section with loss of fat spaces. There is loss of the topography. We can see the immature, the thickening of the granulocytic cell line, and they are occupying the entire space. The presence of the dwarf looking megakaryocytes, increased number of megakaryocytes. So this case, we like on the aspirate and the PBS and the Trephine biopsy, we report it as myeloproliferative neoplasm, most likely CML. Till we do the BCR-ABL translocation, we directly don't label these cases as CML. We write it as myeloproliferative neoplasm, most likely chronic myeloid leukemia, and further classify into chronic, accelerated, or blast crisis depending on the number of blasts. One thing I would like to point out here is that in the peripheral smear, we have seen increased basophilic cells in the precursor. The aspirate also showed increased number of basophils, but on the Trephine section, we hardly see any increased basophil, or we are not able to appreciate those basophils on the Trephine section, because there is a reason. While processing the Trephine section, the basophilic granules undergo dissolution. So the basophils are not appreciated that well on the Trephine section. So to comment on the basophil, we have to comment on the bone marrow aspirate on the peripheral smear. Okay. This is the next case. A 55-year gentleman presented with headache, dizziness, and a history of chest pain. This is the CBC. In the CBC shows hemoglobin, which is characteristically raised 17.5 gram per deciliter. RBC count is 5.77 and an increased hematocrit of 52%. Okay. So this gives a clue that we are dealing with a case of erythrocytosis, because the hemoglobin is increased and the hematocrit is massively increased. This is the peripheral smear. As from the peripheral smear, we can make out markedly increased density of the RBCs. This is a bone marrow aspirate low power view. The low power view, these are the particles which are quite hypercellular, and even the trails are looking very cellular for this age. This is a closer view. The closer view shows the proliferation of the granulocytic cells, the presence of the dysmorphic looking megakaryocytes. This is the Trephine section. The Trephine section is showing increased number of megakaryocytes here. And these megakaryocytes are like varying from the, most of them, few of them are looking normal looking, some are micromegakaryocytes or hypolobated, some are hyperlobated. Plus there is some amount of clustering. And we can see there is markedly reduced fat spaces. There is proliferation of almost all the lineage. We can see these are the erythroid precursors which have proliferated, the granulocytes as well as the megakaryocytes. So there is a tri-lineage proliferation with presence of pleomorphic looking megakaryocytes. So this case was reported as myeloproliferative neoplasm. Kindly evaluate the cause of erythrocytosis. It could be either primary erythrocytosis or secondary erythrocytosis. The primary erythrocytosis is polycythemia, that we call as polycythemia vera. And the secondary erythrocytosis or the secondary polycythemia is because of the some other reason that causes increased hemoglobin and increased RBC count. So secondary erythrocytosis or secondary polycythemia is characteristically seen in people living at high altitude or certain renal neoplasms or in smokers. And now, what are the clues that we can get from the peripheral blood, the bone marrow aspirate and Trephine section, which can help us to delineate whether a case is primary erythrocytosis or a secondary erythrocytosis? Of course, the history is very important in such cases, but if there is peripheral blood basophilia, neutrophilia, and associated thrombocytosis, these findings are usually seen in the polycythemia vera or primary polycythemia, and they are not seen in the secondary erythrocytosis. Second is the Trephine section. In polycythemia vera, the Trephine is usually hypercellular with a tri-lineage proliferation, whereas in cases of secondary erythrocytosis, the Trephine section is either normocellular or moderately hypercellular, but it will not show the tri-lineage proliferation. So these are certain clues that we can get apart from the history, which we can get from the peripheral blood, bone marrow aspirate, and Trephine to further classify. The megakaryocytic abnormalities are absent in the secondary causes of erythrocytosis. So other than these, we have to take up the case further for the mutation analysis, the most important being the JAK2V617F mutation. And if it's negative, then further we proceed ahead with exon 12 mutation and CALR and MPL and all those mutations that we get in BCR-ABL negative myeloproliferative neoplasms. This is another case of the same category, 60-year gentleman with history of repeated cerebrovascular accident. This is his CBC. Okay, this is showing the markedly increased platelet count of 11 lakh cells per cubic millimeter. So platelet count was markedly increased. The hemoglobin is in normal range. The WBC count and differential was in normal range. So abnormality that we picked up on CBC was a increased platelet count. This is a peripheral smear, which is showing the large clumps of the platelets. This is a bone marrow aspirate, which is showing increased number of megakaryocytes. And these megakaryocytes were hyperlobulated with lot of lobulations that we see here. This is the Trephine section. In the Trephine section, we see increased number of megakaryocytes, and there is some amount of clustering in the megakaryocytes and presence of these hyperlobulated or the hypersegmented megakaryocytes, plus increase in these eosinophilic precursors in the Trephine section. So this is a case of, this is how essential thrombocythemia looks on the Trephine section and on the aspirate. There is increase in the megakaryocytes. These megakaryocytes are large in size and they have a hypersegmented, or as it described in the book, a staghorn-like looking like nuclei, hypersegmented or hyperlobulated megakaryocytes. Again, there are certain diagnostic pitfalls. We have to differentiate these cases from the reactive causes of thrombocytosis. Now, what are the clues that we can get from the peripheral smear and from the bone marrow aspirate and as well as the Trephine is that in essential thrombocythemia, in the peripheral smear, we can see a variable size of the platelets. Some of them will be giant looking. There'll be large clumps of platelet. We might see the presence of agranular platelet in the peripheral smear, as well as circulating micromegakaryocytes are often present in these cases. These are the fragments of the megakaryocytic cytoplasm that we see on the peripheral smear. In reactive thrombocytosis, Trephine biopsy is usually normocellular and megakaryocytes are increased, but most of the time they are normal in morphology. So bone peripheral smear along with the aspirate and Trephine biopsy can help us to differentiate the reactive causes of thrombocytosis from the other causes of the thrombocytosis. This is a 70-year male with history of weakness, lethargy, and joint pain. This is a three-part CBC report that was available for this case. We can see the platelet count is raised. The WBC count is also raised. The hemoglobin is slightly on the lower side, 11.1. And the scattergram is showing increased number of the neutrophils here. Okay, this is the peripheral smear. In the peripheral smear, we see the large number of platelets. We see presence of these neutrophils. This is the bone marrow aspirate, which is showing the presence of megakaryocytes, increased number of megakaryocytes with some amount of clustering. This is a megakaryocyte which is hyperlobulated and has got these rounded lobes. This is the Trephine section. Again, we can see there is increased number of megakaryocytes with some amount of clustering of the megakaryocytes. And certain hyperlobulated megakaryocytes. So this was a case of pre-primary myelofibrosis. This is a pre-primary stage of the myelofibrosis wherein the patient has a tri-lineage proliferation. So the CBC will show increase in the either 2-cell lineages or increase in the 3-cell lineages. But the aspirate, the morphology of the megakaryocytes on the aspirate, the kind of megakaryocytes present on the Trephine section, their clustering associated with the reticulin stain. Definitely, we have to do a reticulin stain in all these kind of cases, whether it's a polycythemia vera, essential thrombocytosis, or pre-primary myelofibrosis, because these have almost negligible stage 0 to stage 1 positive reticulin stain. Now, this table is showing the comparison of these three kind of cases that I have just discussed. That is polycythemia vera cases, the essential thrombocythemia cases, and the primary myelofibrosis cases. Just a second. Okay. So when we consider the polycythemia vera, here the cellularity is overall increased. Why this increase in cellularity? Because there is a tri-lineage proliferation in cases of polycythemia. Whereas the cellularity is normal is essential thrombocythemia, and even in primary myelofibrosis, it is normal. Okay. Whereas in polycythemia vera, we see tri-lineage proliferation of all the cell lines, whether it is granulocytic cells, the erythroid cells, or the megakaryocyte. Whereas in essential thrombocythemia, there is proliferation of the megakaryocyte, whereas the granulocytic and erythroid lineage are normal and they don't undergo proliferation. In pre-primary myelofibrosis, there is proliferation of the granulocytic cells, whereas the erythroid cells are usually normal. They don't. There is no erythroid hyperplasia. There is proliferation of the megakaryocyte. Now, looking at the megakaryocytic morphology, how do we differentiate into these three conditions? The megakaryocyte is small to large in polycythemia vera. They are pleomorphic in morphology. Pleomorphic means they are variable in morphology, like they can have normalobated, there can be hypolobated or micromegakaryocytes, or they can be hyperlobulated. And the megakaryocytic cluster is usually absent in cases of polycythemia vera. When we talk about essential thrombocythemia, the megakaryocytes are very large in size and they have a hypersegmented nuclei or the staghorn shaped nuclei. Plus, there will be some amount of loose clustering seen in the megakaryocytes here. Similarly, when we talk about the pre-primary myelofibrosis, the megakaryocytes are again large in size. They are present in tight clusters and have a very dysplastic looking hyperlobulated kind of megakaryocyte, but the nuclei will have a bulbous end. when we compare it with the megakaryocytes of ET. ET had a very sharply segmented megakaryocytes, which we describe as staghorn, whereas here they have a bulbous end. And whenever we are suspecting any of these MPN, we have to do a reticulin stain. Reticulin stain is must in ET and in polycythemia, where almost we don't see any increase in the reticulin fibrosis, where it can be 0 to grade 1 in cases of pre-primary myelofibrosis. So with the help of the bone marrow aspirate as accompanied with the trephine section, based on the morphology, most of the time we are able to zero down to a particular case, like we are able to make out whether it's a polycythemia, ET or pre-primary myelofibrosis from the morphology. This is a low power view. We can see the slightly hypercellular marrow, and this is the reticulin stain in pre-primary myelofibrosis, where the reticulin fibrosis is not that greatly increased. Now, this is a case of primary myelofibrosis. Actually, the peripheral smear is a mirror of whatever is happening in the marrow. So, peripheral smear will reflect what is happening in the marrow. In this case, we see the teardrop cells, we see the nucleated RBC, we see a blast here. So, we definitely know something is happening in the marrow. This is a marrow which is showing increased number of megakaryocytes that are present in clusters, and of course, the presence of fibrosis. This image is showing large amount of fibrosis, reticulin stain, which is showing grade 3 fibrosis, and this is Mason's trichome stain, which is again showing increased fibrosis. This was a case of myelofibrosis. We have to rule out the secondary or reactive causes of thrombocytosis when we are talking about the essential thrombocythemia, and these are all the causes of reactive thrombocytosis. Coming to the next case, 53-year male presents with weakness, exercise, and pruritus. On examination, he has splenomegaly, and these are the CBC findings. We can see the TLC is increased. There is neutrophilic predominance and few left shift cells we are seeing here. This is a peripheral smear showing large number of neutrophils. This is the bone marrow aspirate showing the granulocytic proliferation. This is a trephine section showing large amount of granulocytic proliferation with occasional megakaryocyte and occasional erythroid precursor is seen. So this was a case of chronic neutrophilic leukemia. And of course, while classifying a case into chronic neutrophilic leukemia, we have to keep in mind the WHO criteria of the chronic neutrophilic leukemia. This case had increased number of eosinophils and eosinophilic precursor. This is a bone marrow aspirate showing increased eosinophilic precursor, and the trephine section showing increased eosinophils. So this was a case of chronic eosinophilic leukemia. Again, further classifying the case into chronic eosinophilic leukemia, as per the recent WHO classification, we have to keep the guidelines into the mind before putting a case into MPN. So that was all about MPN. Now a few slides about the leukemias. A 30-year male leukemias often present with the patient will have pallor. They often present with anemia. So any case with anemia, as we usually do, we proceed ahead with the CBC and peripheral smear. This is a CBC showing large amount of these blasts. These are the blasts with prominent nucleoli, moderate amount of agranular looking cytoplasm. And this is the trephine section. The trephine section, we see there is loss of topography, no megakaryocytes seen, no erythroid precursors seen. The maturing granulocytic precursors are also not seen. We just see the sheets of these blast cells. This was a case of acute monoblastic leukemia, like the morphology is very characteristic on the peripheral smear, and these are all the monoblasts that we are seeing here. Coming to the next case, a 60-year male with patient with anemia and backache, and this is a peripheral smear on low power. Most of us know that this is a very characteristic appearance, the increased rouleau formation, and from the peripheral smear, we can get a clue what we are going to see in the bone marrow. This is a bone marrow aspirate smear. We can make out the plasma cells that are increased with many dysmorphic, binucleate, multinucleated forms here. And of course, the pink immunoglobulin deposition, the flame cell that we call the Mott cell here. So this was a case of multiple myeloma. This is a trephine section. The whole trephine biopsy has been replaced by the proliferation of these plasma cells in sheets. So this was a case of multiple myeloma, and of course, along with the bone marrow findings, we advise for the serum protein electrophoresis, immunofixation, etc. In the peripheral smear of this case, we have seen this increased rouleau formation. One thing I want to point out here is that increased rouleau always does not always mean that it is a case of multiple myeloma. The increased rouleau can be seen if there is any other chronic infection which can cause increase in the immunoglobulin levels, the increase in the gamma globulin levels in the blood. So they can also, the chronic infection cases, certain autoimmune disorders can also have increased rouleau formation in the peripheral blood. Another case, a 4-year child with anemia. Okay, the bone marrow aspirate smears are normocellular looking. This is a closer view. These are the granulocytic precursors showing almost normal maturation. But one thing that is quite striking here is that the erythroid precursors are markedly reduced. This is this is again a closer view. We are seeing the left shift in the erythroid precursor. This is a bare nuclei. This is another erythroid precursor, which with presence of some prominent intranuclear inclusion. This is a closer view. We can see the prominent intranuclear inclusion along with the cytoplasmic projections. This is a Trephine section showing presence of these large cells with prominent inclusion. So this was a case of parvovirus B19 infection presenting with anemia in a child. A 50-year gentleman with splenomegaly and palpable cervical lymph node. This is a bone marrow aspirate. And whenever we are examining the bone marrow aspirate, we have to be very careful. Like along with the normals, first we have to comment on the cellularity, then we have to check the granulocytic series followed by erythroid, the megakaryocytes, including the number and morphology, the macrophages. And in the end, we have to check if there is any other atypical or abnormal cell infiltrating into the marrow. And of course, last but not the least, we have to rule out the parasites also. So in this case, we see these are certain atypical looking lymphoid cells that are seen here. This cell, as well as this cell is not good looking. This is another field which is showing presence of large number of these atypical looking cell. And we can, this patient had splenomegaly along with the palpable cervical lymph node. So by this time, we have a clue that, okay, something abnormal, maybe a non-Hodgkin lymphoma is infiltrating into the marrow. These are the imprint smear, and the imprint smear had large amount of these cells which were present, and of course, large amount of bare nuclei. So whenever we are examining the aspirate as well as the imprint along with the normal lineage of the cells, normal lineages, we have to comment on any abnormal cells present, and we have to comment on the bare nuclei also. If there are large amount of bare nuclei seen, that should also be mentioned in the report, because these bare nuclei can be either of the erythroid or they could be because of the lymphoid cell lineage. So we must not ignore the bare looking nuclei that are seen on the aspirate smear. This is a Trephine section that we got, and here clearly we can make out the presence of these abnormal looking lymphoid cells. They are present in clusters. So we know. So now we know that this is a case of non-Hodgkin's lymphoma infiltrating into the marrow. We proceeded ahead with the immunohistochemistry. These cells were positive for CD20. So this is marrow infiltration by B non-Hodgkin's lymphoma, and other than CD20, we have to proceed with the other IHC markers also, which are required for the B cell lymphoma. Now, one thing that I want to point out here is that in marrow, the most of the lymphocytes normally that we see are the T lymphocytes. That is, the most of the population is CD3 positive. So if you see increased number of B positive cells, or if there is any clustering of B positive cells, we have to proceed ahead with the further IHC panel to rule out the lymphomatous infiltrate. This is the last case of today's presentation. A 1-year male with pallor and splenomegaly. The hemoglobin is reduced. The RBC count is reduced. There is markedly increased red cell distribution width. MCV is increased. Retic count is increased. This is the peripheral smear. We see large amount of anisocytosis. We had seen in the CBC also RDW was greatly increased. There is presence of the teardrop cells, We can see certain microcytic hypochromic cells, certain macrocytic cells, large number of nucleated RBCs, presence of these smudge cells. This is a closer view showing the presence of the Cabo ring, the basophilic stippling in these cells. And of course, the transfused cells were also present. So by now, looking at the peripheral smear, the history of the child and the CBC, we have a clue that we are dealing with a hemolytic anemia. This is a bone marrow aspirate showing the erythroid proliferation, and most of the erythroid had megaloblastic changes. So when we are dealing with the hemolytic anemia, especially in the young child, we think about the hereditary hemolytic anemias and we proceed ahead with the HPLC for the hemoglobin variant analysis. Of course, this was the Trephine biopsy showing the increased number of erythroid precursors. And either we can do capillary hemoglobin electrophoresis or we can do HPLC. So this case has increased fetal hemoglobin of 96.2%. So this was a case of beta thalassemia major.